Okay. So often early on, what you guys are learning and practicing is the utilization of a preserve that gives you the ability to answer, 80% of what it is that you're going to see. And so that's pretty good. If you can employ a group of tools that are going to drive you to a reasonable impression 80% of the time, then that's an okay way to begin. But then you think, well, what about those other cases? If I could pick on Bill Weiss for a minute, he had a case last week of a post-sternotomy brachial plexus injury. And so there were things that he would need to pick and to choose to apply that were outside of a standard montage. Is that fair, Bill?
Yeah, very fair. Very fair. It was difficult for me, actually. Difficult.
If you look at the process of electrodiagnostic testing as simply being an extension of your neuromusculoskeletal examination, then if you do a good screen, then your decisions to add or take away things from your nerve study or from your EMG become easier. So a goal that I have and I share this particular algorithm with people that work with me and those that we train within and outside of HODS. So those that I mentor, we go through these types of talks a lot, and those that work with me in our company, we go through this. This actually is is our playbook, if you will, our SOP, our standard operating procedure on electrodiagnostic testing. We all have different preserves that we use, but so long as we follow a basic algorithm in reaching the decision to stop, or that we've answered the clinical question and we can stop testing now, then I think that we're doing okay. So what things I think are important for a quality electrodiagnostic study? It's important to test the order. So oftentimes family practice doctor is going to send you a request for a patient with carpal tunnel. And it's important for you to do what's necessary to demonstrate the presence or absence of carpal tunnel. And that's your primary goal. Now, secondarily, you may run into other things, right? You may run into the cervical radiculopathy that's not carpal tunnel, or the polyneuropathy that may be superimposed or part of the carpal tunnel. And so important that you first assess the order. What's your hypothesis, if you will, going into your study, and how? Sorry, I'm removing folks that are checking in. What's your hypothesis, and what's your plan? What's your plan to answer the question? So it's important to examine whatever's necessary to dispose of the case. And so once you've screened or ruled in the suspecting condition, then it's important that you perform any other procedures that are necessary to finish painting the picture, and then correlate those things so that the provider can choose appropriate interventions. And if you're self-referring in your practice, then those things are also important. So it's important to know when to stop, especially if you start putting yourself on a timeline. You give yourself an hour for an exam or 2 hours for an exam. Well, what's important to test? And I like to look at things as name that tune. How many nerves does it take for me to answer the clinical question and provide enough information that the addition of more information doesn't add anything to my test? And so that's really a rule. When do you stop? You stop when the addition of more EMG or nerve tests don't yield any other information that's going to change what your impression is. And that'll vary. It'll vary amongst you. It varies between myself and Dr. Brooks. It, I'm sure, varies between the two of us and Demi. But what's most important is that your algorithms themselves, the rationale for why you choose to do a nerve, or the rationale for why you choose to add a different nerve or to go a different direction, that's real time, and those decisions are made real time. It's not that you're starting out with that template and you just follow a written protocol, because electrodiagnostics really isn't a protocol, and it varies by patient. If a person came in with weakness in abduction and external rotation, as an example, with numbness and tingling in the lateral aspect of the brachium, maybe some neck pain, a standard montage of median, ulnar, radial, motor, and sensory doesn't necessarily hone in on the fact that the patient's weak in abduction and external rotation of the shoulder. So the importance of adding EMG of the spinatus, particularly the infraspinatus, making sure you EMG the deltoid is important. Alternatively, doing nerve conduction, motor nerve conduction off of the nerves that demonstrate weakness. So you have to be willing to add an axillary motor nerve conduction study. You have to be willing to add a suprascapular motor nerve conduction study. Does that make reasonable sense in the process? Because your short form preserve or upper extremity doesn't necessarily have those components in it, and you're going to see patients that don't fit it, again, probably 5 to 10% of the time. But when those folks walk in the door, we need to know what to do with them. Is that okay?
Yep, it is.
So we talk about this a lot. In fact, we talk about this almost every, I mention these two things almost every time I'm talking with a mentee, a partner, and just about every time that we're on doing a webinar. Basic clinical decisions. EMG is the most sensitive detector for motor axon loss. That will be a question on your ECS examination. So if a CMAP amplitude is normal to low, it's important that we do an EMG, because just because a CMAP is normal doesn't mean there's not motor axonopathy. We see that all the time, right?
Right.
We see patients that have normal amplitude ulnar motor CMAPs off of the ADM or the FDI, but when we stick it, they light up. Well, so if it's normal, the CMAP that is, it doesn't mean that there's not motor axonopathy. So it's important to stick a muscle that you suspect might have evidence of denervation. And conversely, just because a distal CMAP is not recordable or is low in amplitude, when a distal CMAP is low in amplitude, does that mean that they have motor axonopathy?
No.
Why? If you put an electrode on the APB and you stimulate the median nerve at the wrist and it's low in amplitude, does that mean that there's motor axonopathy? I think that was you, Roy, that said no.
Yeah, I mean, in most cases I guess you might say it would be, but,
But how do you prove it?
Stick the
I mean,
muscle.
again, you go do your EMG and just see what
Yeah. Yeah. Who said stick the muscle?
Bill did.
That's exactly right.
It finally sunk in, Rick.
Yeah. Well, but you know what? You are 100% correct.
Yeah.
If and you'll see it, especially if you're practicing in. I need to hit allow to talk and on a couple of people that are here checked in. I'm sorry, guys. I'm working hard.
Mm-hmm.
It's hard for me to work on one on one side and talk on the other.
Right.
But I'm trying. So if you have, and Bill's a CHT also, so he sees a lot of hand patients. Bill, have you noticed in your practice, especially in those that have like a volar collapse of the CMC joint, that you do a motor nerve conduction study off the APB, and those CMAPs are inherently low?
Absolutely. Absolutely.
Yeah. So you have a change in the mechanics of what's happening in a joint, and whether there's atrophy or just whether the mechanics of the muscle have changed. You'll do a nerve study on a 70-year-old, and you'll see a 2.2 millivolt median CMAP off the APB, and the sensories are normal, and you stick the muscle and it's normal.
Yeah.
So does that 2.2 millivolt CMAP demonstrate that there is, in fact, motor axonopathy? No.
Yeah.
What kind of CMAP might you see in a patient who had been in a cast?
Decreased.
Decreased.
Yeah, absolutely.
Simply
Hold
from
on.
yeah.
I just want to explain to people, look, Rick is saying some things that are really phenomenal here. And, you know, this is stuff that is just finally sinking into me, you know, so grasp this information because it makes sense. Just because you have a decreased CMAP doesn't mean you're going to have an axonopathy. And just because you have a normal CMAP doesn't mean you're not going to have an axonopathy. So just
and one thing I'll say too,
apply that stuff because Rick's right on target on this stuff, and it's just the faster you can get a hold of this stuff on that part, the more successful you are, and the less of a robot you're going to be in everything that you do with your EMG studies.
Yeah, and for you guys too that are just getting going, you're going to be looking at this and trying to prove it with the EMG, and you're going to be looking for things that aren't there.
Explain that, Bill. I mean, Roy.
Well, I mean, the thing is you're looking at that, and then you know you're starting to see polys there that aren't there, you know, from the standpoint, or you're going to see waveforms, and you're trying to substantiate your numbers. And I think that's what you just have to kind of watch as a newbie, is that you're knowing and you've got these certain facts in your head, and then you're trying to prove it instead of just taking the what's there.
Right.
So basically, you go from an aha to an oh crap.
It's true.
You think aha, and then all of a sudden you go oh crap.
Uh-oh.
Yeah. Or your mentor tells you that.
But you know, that's what the mentor's there for.
That's right.
And at the end of the day, remember that our goal is competency and quality. And you know, when I give feedback, and Bill Weiss, and I know Dodson, you and I have had this discussion. Yeah. When we give feedback, our goal is to give you the feedback so that you can produce the kind of study that the neurologist that's down the street is going to read and say, okay, he knows what he's doing. Right. Because I guarantee you, for those of you that are practicing that are new in a community where there are other people doing EMGs, they don't want you doing these tests. Mm-hmm. And the last thing that they need is a stack of your work to take to somebody else or to take to your referring providers to say, this stuff isn't any good, quit sending them patients, right?
Right.
And so that's the hardest time to me in a newly developing EMG practice is getting good information and putting out a quality report so that it doesn't become a detriment to your practice because you're making early mistakes. And so it's okay to shoot off a text message to your mentor and say, hey, you got a minute to talk, even if you're live with a patient, because there's nothing more frustrating to me or to you or to the patient when they have to get that call that says, hey, I need to do 3 more things. Do you mind coming back in? But it's going to happen, and it's okay that it happens. In fact, in my 25 years of practice, I don't think I've ever had a patient that's refused to come back or been upset because they had to. Even when I was early on in training, because I try to couch it in a way of, Ms. Jones, we got a lot of good information, but as I sat down and I looked through your data, I see that there are a couple of things that would really, that really don't look quite right to me. And everything's okay. You're not hurt or anything, but I would just feel more comfortable if I could redo 2 nerves and add a different nerve. And I might stick 1 or 2 more muscles, because I really want to make sure that the information that I give to your doctor is exactly what he needs to be able to help you. And if you say it like that, they're going to be okay.
It's worked for me so far.
Good.
And it's worked for me too. So you got to be a good salesman on the fact whenever you mess up, or if you're not doing the right thing, or you didn't do the right thing, you got to sell your patient on the fact that you want to give them something more. You want to give them something better. You want to say, hey, I want to give your doctor the best possible information.
Yeah. And don't say, hey, Miss Jones, I really messed up. I sent my study to my mentor and he bled all over it and said I did a dumb thing and it's my fault and I need you to come back in because I didn't do something right. Because as soon as you say that, what happens to their confidence in you? It's gone. And that's one of the reasons why often in testing, especially on mentor days and things, I almost would rather just kind of sit back and let you take over, because as soon as I interject, patients start looking at me. They quit looking at you. And you don't want that, you want them to trust you. Okay, so if you do a distal CMAP and you don't record something, let's take an instance where we'll use carpal tunnel, just because carpal tunnel we see more than anything else. You do median sensory to D1 and you get no response. And you do a median sensory to D3 or D2 and you get no response. And then you put an electrode on the APB and you get no response. Then you do your EMG and what you write is patient's got severe median very severe median neuropathy at the wrist. Well, I challenge, how does that information help you to confirm where the problem is?
Doesn't.
It doesn't. It could be anywhere on the median nerve, right? If the distal snap and the distal CMAPs are both gone, you suspect that it's at the wrist. The symptoms are there. But what can you do to help to clean that test up? There are things that you can add. You can do a motor study to the flexor carpi radialis, or you can do the anterior interosseous nerve to the flexor pollicis longus, or you can do a mixed nerve study from the wrist to antecubital fossa, which you guys, I don't think you learned, but it's an easy technique, and I'm happy to demonstrate it at some point. But the same thing if you're doing you get no response off the abductor hallucis in a severe polyneuropathy, make a comment about the fact that you were able to confirm proximal continuity of the tibial nerve when you saw a decent CMAP off the medial gastroc when you were doing H reflex tests. you know, so that you're pigeonholing this problem as peripheral, not necessarily diffuse. And then of course you're going to back it up with your EMG, right?
Right.
And the peroneal nerve or fibular nerve is the same thing. If you stimulate at the ankle and you're recording off the extensor digitorum brevis and you get no response at the foot, well, move that electrode straight up to the anterior tibialis and then shock below the fibular head, above the fibular head, and see. And those need to become routine, algorithmic decisions that if this, then I'm going to do it alternatively. And it'll help you. It'll help you get faster, and it'll help you make sense of things. We cool?
Yep.
Okay, so basic clinical decisions. When we need to find out whether someone has a radiculopathy, the old Dillingham studies on radiculopathy say that we need to test a minimum of 5 to 7 muscles to produce the greatest detectable yield for radiculopathy. That's a complete study, 5 to 7 muscles. You may stick the FDI, the FCR, the brachioradialis, the EDC, the tricep, the deltoid, maybe the bicep, and that's a reasonable screen from C5 to T1.
Mm-hmm.
You know, in the lower extremity, it might be the posterior tibialis, the medial gastroc, the anterior tib, the peroneus longus, a couple of quads, a couple of hip muscles, and paraspinals. And that's a reasonable screen for radiculopathy. Now, if you don't suspect radiculopathy, do you have to stick the same amount of muscles?
Yeah.
Maybe not.
Mm-hmm.
Okay. But what is important is that we're at least screening enough yield, enough muscles to be a sufficient yield to detect a radiculopathy if it's there. And a minimum of 5 to 7 produces our best yield for radiculopathies. Any questions about that? So I see, go ahead.
So, I mean, it's just as important to rule in as it is to rule out.
Yes.
And so that's an important thing for especially the newer, I mean, I say newer because I feel like I've been around for a couple of years, but the newer people will say it's just as important to rule in as it is to rule out.
Yes, and I think it's I think maybe what you meant to say is that it's just as important to rule out as it is to rule in.
Both ways, yes.
Yeah. So here's, and patients will say that too with like carpal tunnel. They're like, why are you sticking me in my shoulder when my problem's in my hand? Mm-hmm. And that, or they'll, so just from a coaching perspective, how you talk with your patient? Well, here's what I'm doing and here's why I'm doing it. Right now, I'm making sure that you don't have damage to a nerve coming out of your neck and into your arm, because just as Bill said, it's just as important to tell your doctor what's not going on as it is to tell him what is. And the same thing with I had a patient today. This is the first time ever in my career I've had a man who I said, I need for you to put on, he had a horrible, he had a cauda equina, but it really was a left L5S1, right S1 polyradiculopathy, but it was very severe. I asked him to put on, he wore jeans and his jeans were kind of snug. And I said, I need for you to put these shorts on for me. We had paper shorts in the clinic. And he was like, I'd really rather not. And I said, what? He was like, well, you're only going to test from my knee to my foot. That's the only place that I'm having problems. And I said, well, no, I'm not going to just test from your knee to your foot. I'm going to test in your thigh. I'm going to test in your hip. I'm going to test in your back. But you can't put on a pair of shorts for me. And he was like, I'd really rather not. And we were able to get his jeans. He really did have a lot of atrophy. And I was able to get his jeans up to like distal third thigh. And then at least he could unbutton and I could pull him over his hip. But that's the first time in my career I've ever had a dude say, no, I'm not going to put on a pair of shorts. I thought that was odd.
Yeah.
But at any rate, that's we're off track. It's okay. Hey, Bill.
Thank you. There you go. There you go.
Focal neuropathies. It's important when you're thinking about looking at focal problems versus diffuse problems in making decisions on what segments are most important. Therefore, in a focal neuropathy like carpal tunnel, if you only do long segments like wrist to digit, and say you do wrist to digit 3 or wrist to digit 2, and it's normal, say it's 3.5 milliseconds, does that mean that they don't have median neuropathy at the wrist?
No.
Why?
Well, I mean, the factor is it depends on where the compression is on the nerve.
No, okay, let's just say that we think that the compression on the nerve is at the carpal tunnel.
Right, but
so if you put a stimulator on the wrist and you record at digit 3, you're testing across where you think the problem is.
Right.
And let's say it's 3.5. That's normal, isn't it?
Yeah, that's normal.
Okay. But is it?
Well, you'd have to do comparative to be sure.
Ah, okay. So Roy said, well, we need to do a comparative study. So like what?
I would test the palm first.
Okay. Or test the palm. Okay. So we're going to do a comparative study of the palm to digit latency to the transcarpal latency. Or, as you just mentioned, maybe we so what you've both said is correct. Comparison studies, maybe we test the radial nerve to digit 1 and compare it to the median nerve. And so what if it's 3.0 in the median nerve, but it's 2.2 to the radial nerve? That's 0.8 milliseconds difference, and that's slow.
Yeah.
And if it was 3.5 to digit 3 and we stimulated in the palm, and the palm was say 1.6 palm to digit, well, 3.5 less 1.6 is 1.9, and 70 into 1.9 is less than 39 meters per second, and that's slow. So in a focal neuropathy, the longer we have that segment, the more we test segments of nerve that are normal that contribute to the latency or the velocity that we're looking at. So here's a real life example. If you're riding down the expressway and we decide we're going to leave my house at the same time and we're going to go 2 different directions, and there's a stop sign and we've got to go 1 mile, and a 1/4 mile into the drive, there's a stop sign, and I have to come to a stop, and then I have to start again, and we've got to go 1 mile. Is my average speed, just because I had to stop at that stop sign, going to be significantly different than your average speed not having stopped over 1 mile?
Oh, yeah.
It is? It's going to be that big a difference? It's not going to be that big a difference. If we've got to go 1 mile and I have to stop at 1 stop sign for 5 yards, and then I can pick right back up to normal speed, we're going to get there pretty close within a few seconds.
True.
Right?
Yeah.
Okay.
I guess it depends on if the person stopping at the stop sign is on their cell phone versus a California stop.
Well, here's the point with respect to focal neuropathy. What if we had to go 20 yards and we said go, and I had to stop at a stop sign in from the time I started, I had to stop at a stop sign to get to the 20-yard line.
Yeah, that'd be different.
Yeah, you would get there twice as fast as I would because you wouldn't have to stop. So if you extend that segment length, oftentimes what happens is you bleed out. So as an example, if over a 14 centimeter segment, you have focal compression in 1 centimeter at the carpal tunnel, you have 13 centimeters of conduction velocity that are normal and only 1 centimeter that's abnormal. When you average all those conduction times together, they come out to be normal. But if you shorten that segment to 6 or 7 centimeters, and you've got a problem in 1 centimeter, now you're compounding the effect of that slowing over the short segment when you test it short, or when you test it to an alternative nerve. So in focal neuropathy, short segment and comparative studies are most sensitive to confirm the presence of focal problems. Conversely, if you suspect that a patient has diffuse or segmental demyelination, that is, multiple segments, long segments have areas of demyelination, or they've got diabetes, then long segments give you the most information. Patients got Guillain-Barré syndrome, a segmental demyelinating condition. Long segments is where you're going to see the change, because you may see conduction velocities or latencies that are just at the upper or lower limits of normal. You see, tibial latencies at 6.1, or you'll see segments that are at 37 or 36. But then you do an F wave and it's 72. Or you do an H reflex and it's 45. And it's more pronounced because now it's slow for that entire mile trip. That make sense?
Yeah.
So a lot of it depends on what it is you're looking for. And then you decide what I'm going to employ. Okay. So condition-specific algorithms. These are based off of the AANEM's practice parameters for nerve conduction testing, given specific conditions, with a flare of experience. Okay. But for the most part, they're practice parameter driven decisions. Again, because I've developed my clinical practice based on expecting that somebody that is in the AANEM is going to get hold of my studies and they're going to want to review them and decide whether I'm worth the crap or not. So I'm CYAing as I test. I want them to get my work. So if we suspect that a patient has carpal tunnel syndrome, we need to test a median sensory long segment. 14 centimeter segment, digit 2 or 3. And we need to test a median motor study off the APB. Now, if either or both of those are normal, then we need to do the short segment tests and do a short segment transcarpal segment to an adjacent segment or to an adjacent nerve. So that is the short segment or comparative studies that you guys talked about. And what are the options that we have available to us? Those are some examples. We can do a median radial comparison to D1. We can do a median ulnar comparison to D4. We can do a median ulnar transcarpal comparison. It's an orthodromic technique where you put electrodes over the median nerve, over the ulnar nerve, you stem the median nerve in the palm, you stem the ulnar nerve in the palm, and you do the same, 0.4 millisecond to 0.5 millisecond difference. And if it's greater than that, it's abnormal. We can do a short segment transcarpal motor. We can do the lumbrical interosseous study to look at the median and ulnar motor comparisons. So there are a number of things that we could do. Now, if we see that 1 or 2 of those are abnormal, do you need to do the rest of them?
Yeah.
Huh?
I don't think so.
I don't think so either. So I kind of, especially if once we've confirmed, Dodson, you had made a comment. once you've confirmed the presence of the problem, what's your job?
To confirm the presence of no other issues.
That's exactly right. So if we can agree that at the beginning of the algorithm, what we agreed was we're going to name that tune. If we've named that tune in 2 notes, do we need to let the song play for 4 more to just show more stuff? No, it becomes more important to me at that point to demonstrate what's not the problem.
Mm-hmm.
So if I do a long segment D3 and a short segment D3 and 1 comparison study and they're all slow, I'm not going to go and start doing interosseous lumbrical comparisons, shortened segments for motors, all kinds of stuff. I've got the problem. I've identified it, and I got enough information to apply it to a grading scale to tell me how bad it is.
So the analogy is, you may think that you have Under Pressure by Queen and David Bowie, but you might have Ice Ice Baby.
Yeah. Well, there's an extra dun in the dun dun the dun 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 dun.
Right. So I mean the whole
Right. I think you're right. Half the people here don't understand.
Don't understand that. They don't.
That's okay.
They don't get that stuff. I apologize. It's
and of course in carpal. So does that make sense for carpal tunnel? Now, on the flip side of that, I've been known to a patient comes in, they have nocturnal hand paresthesias. It improves with a flick sign. Intermittently, they get numbness and tingling if they drive a car or talk on the phone. Now, clinically, that's the definition of what? Nocturnal hand paresthesias, improve with a flick sign, and then, if I'm running a weed eater, riding my bicycle, talking on the phone, or driving a car, occasionally my fingers will go numb. That is carpal tunnel syndrome.
Yeah.
So they have carpal tunnel syndrome. Our job is to decide whether they have median neuropathy at the wrist or not. Right? So if I do median radial D1 and it's normal, and I do a median D3 with a short segment and it's right at the borderline, I've been known to add D4. I've been known to add the lumbrical interosseous comparison. And if I test D4 and I say, hey, well, that's clearly abnormal, and the interosseous lumbrical comparison's clearly abnormal, with everything else being normal, I've just identified very mild median neuropathy at the wrist with symptoms of carpal tunnel. So it's okay to do more. My issue is once you have it, why do you need to keep doing it?
I got one question for you, Rick.
Sure, man.
So I thought the internal comparison studies for median to ulnar, median to radial were most sensitive we had. Did I get that correct, or do I have it?
Yeah. Yeah, the short segments and comparison studies that we have are the most sensitive studies that we have for the detection of focal neuropathies. Now you go looking at sensitivity and specificity for multiple different nerve studies. Some are going to say the short transcarpal latency over 7 centimeters is the best. Some are going to say that the lumbrical interosseous study is most sensitive. Some are going to say that the comparative study to D4, D1 is most sensitive.
So basically, Rick, when you're saying, if you've examined a patient and you're talking to a patient and they're saying they have all these subjective symptoms, okay, and you don't have anything from the D3 transcarpus comparison to and then also the, that it's good to start looking at other areas of the median nerve.
Yes, and remember that is if they have symptoms of carpal tunnel syndrome.
Right.
So if they don't have symptoms of carpal tunnel syndrome and they have cervical radiculopathy, I'm doing those studies as a screening tool.
Sure.
To demonstrate that they don't have a problem. So I'm not going to chase down median neuropathy at the wrist in a patient that doesn't have symptoms of median neuropathy at the wrist. In fact, I'll write, you'll see a patient who has slowing around the elbow. and you beat on that nerve and you do flexion and compression, and they tell you flat out, I do not ever have numbness in my pinky, but I still see that it's a little bit slow.
Right.
I'll make a statement that there's mild slowing of the ulnar nerve at the elbow, but this doesn't correlate with the patient's clinical presentation.
So could that mean that they have more of a motor injury or a motor problem than they do a sensory problem?
Well, I think that it could mean that they may have early signs of more diffuse problems to come.
Right.
Probably more often than not, what that means is you go to the other side where they say, I don't have any symptoms at all on my right. Now, all my symptoms are on my left, and it bothers me when I wake up at night, blah, blah, blah. And you've confirmed the median neuropathy, but then you also see the ulnar nerve slow at the elbow. You can almost predict that in that patient, you go to the other side where they say, I don't have any symptoms. You're going to see similar but less slowing of the median nerve at the wrist and the same mild slowing of the ulnar nerve around the elbow.
Yeah.
And then you go, now I'm obligated to do what, Bill? Bill Wise? Now that I have 2 median neuropathies at the wrists and 2 ulnar neuropathies at the elbow, what am I going to tell you to do next?
Lower extremity, sensory and motor.
Yeah, and I'm going to tell you to test the sural and the peroneal motor. And then you test them and they're good. Well, great, stop. Now what you have is I've got multiple areas of focal entrapment, but 3 of them don't make any sense to me. The ulnar nerve and the affected side doesn't make sense. The median nerve and the ulnar nerve and the unaffected limb don't really make any sense. But I screen the lower. And so I'll write something along the lines of, often early peripheral neuropathy may develop with multiple areas of focal entrapment. We screened the leg and there wasn't sufficient evidence to confirm more diffuse neuropathy, but should symptoms develop, repeat study may be helpful using these findings today as a baseline. So you can go back and compare, is that getting worse or not? And then sure enough, 20 years later, that patient's got diabetes and now they're starting to feel numbness in their feet.
Rick, just real quick.
Uh-huh.
I mean, we look at diabetic. I mean, I see a butt ton of diabetics down here.
Right.
And I mean, do you really think that these tests, even though they say, well, I've never been diagnosed with diabetes. My A1Cs come out great. My blood sugars come out great. And you go, hey, but wait a second. Here are some issues. Do you think that this might even be more sensitive than some of those other issues, other tests?
I think that, excuse me. I think that it's been demonstrated in the diabetes literature that early carpal tunnel is a correlate to the development of later non-insulin dependent diabetes.
Wow.
So I'm a fat 50-year-old.
Good looking.
With, yeah, well, we didn't even have to argue about that.
Yeah.
Who has carpal tunnel.
Mm-hmm.
Now, I don't have ulnar neuropathy at the elbow, but I have noticed that over the years that I've been testing that my EDB amplitudes have been shrinking. Now, I don't have peripheral neuropathy yet, but it wouldn't surprise me that when I get to the age of 60 or 65, if I don't do something for myself, that I might wind up with non-insulin dependent diabetes.
Mm-hmm.
So, yeah, the answer to your question, Bill, is yeah, I think so.
Mm-hmm.
Okay. So in addition to EMG muscles from basic C5 to T1 myotomes, consider sticking the APB, especially if the CMAP is normal or abnormal. Sample at least one other sensory and motor nerve to confirm that it's isolated to the median nerve, and then consider side-to-side comparisons when symptoms are present. And remember that CTS happens about 70% of the time bilaterally, because it tends to be really more of an anatomy problem. Things are just tight there. So even if a patient doesn't have symptoms on the other side, they may still have evidence of neuropathy on the other side.
Can I interrupt you here again? I'm talking
Sure.
a lot this today. I don't know why I'm talking so much.
Because we hadn't talked in a while.
I know. I freaking miss you. But I'm going to be giving a speech at in Atlanta.
Okay.
Talking about the transcarpal ligament and how important it is, and looking at the thickness of it on people who have carpal tunnel syndrome, and how we are going to use musculoskeletal ultrasound to help treat that with dry needling. And I want to let you guys know that, is it a structural problem? Is it mechanical? Is it the fact that things are, the transcarpal ligament is unbelievably complex. And so what we're going to be doing is showing a new way of treating it via carpal tunnel via musculoskeletal ultrasound, and then also retesting it using electrodiagnostics. So just an update on that. And I'm really excited about presenting this presentation.
Cool. I can't wait to see it.
Yep.
Anybody else besides Bill presenting? I'm going to do a short talk called Beyond the Preserve. And it's pretty much going to be what we're talking about right now, but just out of the box thinking about nerve conduction and EMG. So let's do one more. Ulnar neuropathy at the elbow. So this is important to me. If you work with me and you suspect that a patient has ulnar neuropathy at the elbow, please do not stop with your above elbow stimulation site. Try to benchmark or bookend your focal neuropathy by giving me a forearm segment, an across the elbow segment, and then a brachial segment. So add a fourth site of stimulation. And sometimes those are they listed on your preserve that way? Or do they stop at above elbow?
They're listed.
Yeah, we're getting one more above.
Okay, good.
Yeah.
So you've got an above elbow and then you have an axilla. Perfect. When you see ulnar neuropathy at the elbow, or you suspect ulnar neuropathy at the elbow, give me the segments below and above every time.
Mm-hmm. Right.
The only time that you're going to have a problem with that is when you do alternative testing off the FDI, because there's really no way that you can prevent volume conduction from the thenars influencing your axillary stem site when you're recording from the FDI. You're going to volume conduct the median nerve, and that's going to change the morphology of that waveform in the axillary study. But at any rate, ulnar neuropathy at the elbow, standard is 8 to 10 centimeter segment around the elbow. If it's normal, then test off the FDI and compare and look at those comparisons from the forearm to brachial segment. So as an example, if I've got a 62 meter per second forearm and a 47 across elbow and a 64 axilla, is that normal?
No.
No. And so when I see that testing from the ADM, I'll test off the FDI, and I may see 62, 40, 62.
Mm-hmm.
Well, now I've got a confirmed segment that's slow around the elbow and a comparative segment from the ADM. If it's still right at that borderline, consider shortening your segment and do inching, either a 4x2 or a 2.5x4 method, where you're kind of walking it around your elbow. You guys learned the 2.5x4 method, I think.
Yes.
Is that correct?
Yes.
Okay. Some people use a 4x2 method. A fellow by the name of Omajek out of Norway. There are some Norwegians that are doing some really neat musculoskeletal ultrasound and electrodiagnostic studies on the ulnar nerve, and they do a 4x2. So they bisect the medial epicondyle. They test 4 centimeters distal, 4 centimeters above for an 8 centimeter segment, and they just do they do 2 4 centimeter segments to look for whether it's a humeral-ulnar arcade, the HUA, which is just distal to the medial epicondyle, versus a retroepicondylar groove, which is typically proximal. And slowing proximally happens more. So retroepicondylar groove problems of the ulnar nerve are more common than humeral-ulnar arcade problems. But it's not going to change a surgeon in their decision to decompress, but it's kind of neat. I think it's important, if you suspect the problem, again, based on the patient's symptoms, and you think they've got ulnaropathy at the elbow, to do what you can to shorten that segment to confirm or deny the presence of the problem. So, any question about motor study and ulnar neuropathy at the elbow?
No.
Okay. If you send a case in where you have 60 in the forearm, 48 across the elbow, and that 48 is normal, and you stop right there and you send it in and say, there's no problem with the ulnar nerve, is that okay, Bill Wise?
No, you ding us one too many times. It's not okay.
Not okay. But you got it though, right?
Correct.
Perfect. So what about sensory nerve testing in ulnar neuropathy at the elbow? If you do D5 and they have numbness at D5, and you test ulnar nerve at D5 and it's normal, does that mean that they don't have a problem at the elbow? No.
No, not at all.
Not at all. You're testing the distal segment, right?
Right.
In fact, the distal segment in ulnar neuropathy at the elbow is only going to be involved with a CMAT or with a SNAP when it's a high, moderate to severe. Otherwise, any very mild ulnar neuropathy at the elbow has a very normal SNAP, because we're only looking at the nerve distal to the lesion. No Wallerian degeneration in very mild and mild. No axonopathy in very mild and mild. So sometimes people say, well, what about testing alternatively? If we have a problem with the sensory nerve to D5, let's test the dorsal ulnar cutaneous nerve, because the duck is going to help us to differentiate whether this problem's at the wrist or at the elbow. Is that a reasonable decision clinically? There's a lot of argument about this. So if you said yes or no, it would be okay.
I would say yes, because the duct goes around the Guillaume's canal.
Yep, not involved at the wrist. Yep.
Right, and just in case there might be something involved with the Guillaume's canal, for instance, if you have somebody that uses a jackhammer,
yep,
or somebody uses a hammer a lot, those might be some issues. Other than that, I just don't see. You just need to look at what's going on with the patient.
The duck is great to use in a low trunk medial cord plexopathy. In ulnar neuropathy at the elbow, I just don't find a lot of usefulness of the dorsal ulnar cutaneous nerve for a couple of reasons. If 50% of the time in ulnar neuropathy at the elbow, the dorsal ulnar cutaneous nerve is spared because it rides in its own fasciculus. Mm-hmm. So even in significant ulnar neuropathies at the elbow, the duct's normal anyways. And that makes me pause and pause hard. In fact, if I were trying to test Guillaume's canal and I wanted to see involvement, I would try to develop, and this is sort of the beyond the preserve. So you guys are going to get a head start on my beyond the preserve talk. If I suspect that someone's got Guyon's canal injuries, I'm going to do transcarpal ulnar sensory studies to D5. And I'm also going to do transcarpal motor studies to the FDI. And I think that there may well be better information gathered from that than just testing the duck. But a lot of people don't test that way. But I try to design a test and then do it side to side that's going to give me the best information to test the problem. I just don't see that much usefulness other than lower brachial plexopathy for the dorsal ulnar cutaneous nerve, just because even in significant ulnar neuropathy at the elbow, the duck spared 50% of the time. So it's really a crapshoot. It's a tough nerve to test to ID a problem, because you're also testing only the distal segment. You don't do an across elbow duck, and most people don't do an across elbow ulnar sensory study, but you can.
So just because it's fun doesn't mean you should do it.
Right.
I'm joking. I'm joking.
Yeah. But the answer is yes.
Now, Rick, you said transcarpal FDI you do. What was the other one you do?
A transcarpal ulnar D5.
Okay.
Right.
Sensory study.
Is that done the same way the median sensory is?
Exactly the same way. Yeah. Just over the ulnar nerve.
What about across the elbow sensory for the ulnar?
Yeah, you can do it too. There's some decent data. 53 meters per second is your norm.
And you just move the stimulator up above the elbow?
Yeah, test it below the elbow and above the elbow. Now, one of the things that you need to be considerate of when you test a long sensory segment is you're going to get a significant drop in amplitude between the distal stem site and the below elbow stem site. You'll see the same thing in the median nerve because of a phenomena called phase cancellation. I'm sure that that's in your instrumentation or modules. So don't look at the amplitude at the wrist and try to compare it to the amplitude below the elbow. It's not going to help you. It's going to drop.
More helpful just to look at the velocity?
Yes, more helpful to look at the velocity around the elbow. And that short segment over 8 and 10 centimeters, Tom Rudiger is a guy that studied that particular technique. Interesting, his normative data and our lab's normative data were exactly the same. But he looked at how much drop in amplitude around the elbow in a normal group versus an ulnar neuropathy at the elbow group was acceptable. And he came up with right at that 50% marker for those of us that believe that there's such a thing as sensory conduction block. Real similar to the transcarpal segment.
Okay.
But when you get that segment out there at, 15, 20, 22 centimeters, and you're doing a sensory nerve study, getting a NAP or a nerve action potential, a SNAP, you can't compare a shorter segment to a long segment in amplitude because of phase cancellation. And phase cancellation is easy to look up. It's in your Dimitru. It should be in your Kimura. And if you have questions about what phase cancellation is, I can draw it out for you. Okay, and then of course EMG testing muscles again, the basic C5 to T1 with appropriate ulnar muscles. Now, when I look at ulnar neuropathy at the elbow, or any neuropathy for that matter, I try to find abnormality in the most distal or most affected muscle first. So if a patient's got weakness in the FDI, I stick the FDI. And if I see abnormality in the FDI, I go to the most proximal muscle distal to the lesion. So if it's at the elbow, I'll stick the FDI and the flexor digitorum profundus ulnar half. And I'll skip the ADM. If I stick the FDI and it's clean, then I'll stick the ADM. And if the ADM's clean, I stop. Because the forearm muscles are less involved than the distal muscles, typically in uni. And then just make sure that if you do see some abnormality, that you stick some other C8 stuff. Any comments, questions about ulnar neuropathy at the elbow? Everybody cool?
Yeah.
Okay. So bottom line, ulnar neuropathy at the elbow. You test off the ADM, motor study, 8 to 10 centimeters. If it's clearly abnormal, there's no reason to test the FDI. There's no reason to go do inching. Bookend it. Give me a normal forearm segment. Give me a normal axillary segment, a normal distal latency. Do the median motor. Do an ulnar sensory. Do one other sensory nerve, like the median, and show me that it's normal. And do a basic EMG screen, and you're good. But if the ADM is normal, you need to do more. Consider the FDI. Consider short segment studies. Compare that forearm and brachial segment to the across elbow segment to see if there are comparative differences. Because focal neuropathies, we look at short segments and comparisons. It's the most sensitive detector that we have. Okay? And that's pretty much a canned algorithmic approach to carpal tunnel and a canned algorithmic approach to ulnar neuropathy at the elbow. If you do those things and you're willing to adjust your montage, or I call it a montage, but if you're willing to adjust your preserve and be sure that you add those things when you suspect those conditions, you're not going to miss. Okay?
Yeah, sounds good.
All right. So what time is it now? It's 8:40.
Yep.
You want to pick back up here when I come back next, or you want to keep going?
Let's
I'm
pick
fine to continue.
Let's pick back up next time. You guys do this every week. You got us for a good hour, hour and a half.
Yeah.
And listen, if anybody has any questions, whether I'm your mentor or not, if you've got a question and you need a response, you can reach out to me. You can reach out to Dr. Brooks or to Demi or to Lugo, whomever. We're here to support you. So I just want everybody to be better.
Sounds great.
Thank you.
Okay, guys. Well, we'll pick this back up next time I'm on the schedule, and we'll keep rolling. And I'll shoot out I failed to do that today. I was busy today. I usually would try to send something out that said, hey, I've got the webinar tonight, and this is what we're going to talk about. But I'll do this next time I'm on.
Awesome.
Thank you.
You're very welcome, guys. Hey, good luck, and I look forward to seeing everybody, meeting new people in Atlanta, and if you need anything, let us know, eh?
Sounds good.
All right, guys.
All right. See ya.
Have a good night. Josh, you still on here?
Oh yeah, I am.
No, not Josh Vance. I'm looking at Josh Rue in the fine sunglasses. I see that he's on, but he Let me unmute him. He won't let me unmute him. He's hiding. I'm not, Josh Vance, where are you?
Where am I? California.
Yeah, you're in California. Cool. Who is serving you?
John Lugo.
How's it going?
Good.
Good.
Yeah.
How far along are you?
Well, I'm off to New York tonight for stage 3-4.
Oh, excellent. Good for you, man.
Yeah, we're pushing along.
Well, I hope it's going well.
We just keep learning more and more. So, and I really appreciated this. It was great. I like those protocols, for lack of better words. Very helpful.
Good. Well, it's a thought process, right?
Yeah, so that's getting in there slowly.
Yeah, but you know what? You'll hear from over time from Lugo and from Brooks and from myself. You're going to hear the same things over and over and over. And like my next 3-4 webinars are probably going to be webinars that I've done before, but it's so important, and people don't get it oftentimes when they sit and they listen to a webinar that's already been done. And is also one of the reasons why I try the best I can to force people to not mute themselves during a talk, because they need to participate. You know, you got to hear it, and you got to acknowledge that, yeah, I understand it. And if you listen to Roy Adams, Roy would say no, and I'd say why, and then he'd fumble, right?
Right.
Because I was trying to force him to think it through. He was answering it right, but he needs to understand why he said what he said, right?
Absolutely.
And so those questions are going to come back and come back and come back. And, you know, you guys are going to get what you need, but, you know, just keep plugging at it, and hopefully it's making good sense to you, eh?
It's coming bit by bit. Really
Good.
appreciate it all.
Good. Hey, good luck. I appreciate the kind words, and I look forward to meeting you.
Yeah, thank you.
All right, man. Have a good night.
You too. Bye-bye.